It's my pleasure to introduce the next speaker. That's correct order, right? Okay. I'm still checking to make sure everybody's got me on track. It's my great pleasure to introduce the next speaker. It's really important, really a pleasure for me because not only is he my mentor, but also my friend. Dr. Ellison had the foresight to, or perhaps the poor judgment, to hire me based on the recommendation of a surgeon that he knew 21 years ago to be a fellow at Ohio State. Like I said, he's not released me from that obligation yet, and it's been a great environment to grow with a great mentorship. Dr. Ellison's the Zollege Professor of Surgery at the Ohio State University. He's really a leader and an icon in American surgery. He's been president of the American Board of Surgery, currently serves as secretary of the American Surgical Association. He's built his career at Ohio State after coming there, and he's published over 100 peer-reviewed articles and is the editor of the Zollege Atlas of Surgery, a legacy atlas that has guided many of us and many of people throughout the world in many different languages through surgical procedures. He's worked recently on the manpower shortage in surgery and is co-author on The Coming Shortage of Surgeon, a book that defines the impending shortage. He's been very active and a leader in American surgery. He's still an excellent technical surgeon and one that I ask for consultation on all the time. He's recognized as an excellent clinician, a gentleman, and an educator. My friend, Dr. Chris Ellison.
Thank you, Scott. Wow, that was quite an address by President Melvin. And I have watched him during his journey, and I'm extremely proud of the accomplishments that he's made. Today, I am greatly honored to give the named lecture at SAGES for Dr. Gerald Marks. And really, when I was first asked to do the lecture, it was right after the American College of Surgeons meeting last year, and the Martin Foundation lecture was on regulation and innovation, and can innovation be sustained during an era of regulation? And to me, SAGES has always represented the house of innovation in surgery, and I thought that it would be incredibly important to gauge the role of innovation and how to be successful in this era of innovation when we also introduce the complexities of quality and safety and now superimpose that on an accountable care and value-based economic model that we all face. I have no disclosures to share. Dr. Marks is an exceptional human being and man. He is known as a physician. He is a great father and family man. He is an outstanding educator. He is an innovator, a truly creative individual. He is the founding president of SAGES, and he is an artist as well. And I think that his ability to put life into a blank canvas really capitalizes on the point of innovation as being critical for his life and the lifeblood of SAGES. These are several of his works of art that I was able to find on the internet, and they certainly don't do them justice, but he is an incredibly creative individual. As a gift to Dr. Marks, I will be sending him from the Ohio State University a Script Ohio, not quite equivalent artwork for his accomplishments. However, it is something to relate the importance SAGES has made to our institution at the Ohio State University. It was very hard to get the marching band to do this, actually. The specific objectives for today are to describe methods available for assessment of clinical practice. We need to understand the application of quality and process improvement, how to measure success. We have to know our available benchmarks that we can compare clinical practice at our institution to that at other institutions, and we need to be able to apply the clinical elements and critical elements of practice assessment. And finally, I'm going to teach you through a small exercise about how to apply what I call a quadrant methodology for assessing the practice and using that practice assessment as a tool for coaching, mentoring, and leading. Now, painting our blueprint for quality and safety, and in particular because of the heritage of Dr. Marks, I thought I would organize my talk today around the 7 elements of creating a piece of art. Painting is divided into 7 outline pieces. 1 is you need to study your subject. 2, you need to provide the foundation, or what's called the underpainting of the canvas. 3, identifying the building blocks or the big shapes that will make your masterpiece. 4, the value study. What are the light elements? What are the dark elements? What are the results? Color in the detail to get to the individual, and adjusting color and value for more focus. And finally, when you think you're done with the painting, don't add any more and leave some to the imagination of others. To begin the artwork, we need to begin with a blank canvas, and that means we need to study our subject. So today we're talking about optimizing the future of surgical care in an era of quality, safety, innovation, and accountable care. What will be the challenges? What will be the solution? What is our formula for success? What are the critical elements we need to know about our local care environment? We need to know our mission, and we need to know our business. And I will share with you some of the elements that we've gone through in our journey for optimizing the future of surgical care at Ohio State. It is my opinion that 3 domains will merge to influence the future of care of the surgical patient. These include quality, innovation, and value. The high demand for quality care, technological advances in innovation, and then value-based accountable care. Our challenge will be to develop successful strategies to continue to meet the demands for providing high-quality care in a safe environment while pursuing innovative technological advances to improve patient care in a value-based environment. The solution is not simple. We will need to solve the value equation by designing our blueprint for quality and safety. Now, normally, when you see the value equation, it includes 3 elements. Value equals quality divided by cost. In my assessment, value equals quality times 2 plus innovation divided by cost. If your quality drops and your cost goes up, your value will be less. Knowing our organization, we are a complex organization, and I'm sure many of you work at complex academic medical centers as well. We have 5 hospitals. We have 1,200 beds. We have 125 intensive care unit beds, 300 step-down beds, 46 operating rooms, annual admissions 58,000, annual observation bed visits 7,000, annual surgeries 30,000, 17,000 employees, 880 physicians, 700 residents and fellows. Pretty large, complex organization. And in order for you to get a handle on how to manage quality, you really have to know what your organization is like. And you need to know your mission. High quality, safe care, innovation. Clearly, we're an academic medical center. Research, innovation, development of new technologies is critically important. We're committed to education and research. We have to know our business, and you know, healthcare is a risky business. We are aligned with bungee jumping, extreme mountain climbing, motorcycle racing, and categorized as a dangerous system when one looks on this assessment, considering the ultra-safe systems of airlines, nuclear power, and other items as mentioned. Training is also a risky business. If you look at the Maslow diagram for training, and we've all trained and we're all involved with training residents and fellows in new procedures. I can remember when laparoscopic cholecystectomy first emerged as an operation, training the unconscious incompetent individual, going through conscious incompetence, then conscious competence, and so forth, until eventually you develop a mature practice. This takes time. And during that time, the learning curve is evolved, and during that first part of the learning curve, there is risk. So when we innovate, we need to develop a practice pattern of introduction of new procedures that minimizes and mitigates against that high risk in the early part of the learning curve. And we can only do that through really having a outlined and quality profile and blueprint. Well, let's go to the next step in the painting, and that's the creating the foundation or the underpainting of the canvas. We looked at our three elements: maintaining high quality and safety, and I believe the foundations are monitoring, detailed clinical practice assessment, and reduction of variability. In addition to advancing our surgical and endoscopic treatments, we have to have a pioneering mindset, but as I indicated, we have to mitigate the risk of introduction of new procedures. And we have to do this by thinking about the value of our services and providing cost-efficient care. The foundation of quality, in my opinion, relies on creating a culture of quality and safety, measuring outcomes, standardizing process improvement, and choosing benchmarks for comparison. Step 3 of the painting is the building blocks, the big shapes. I think that optimizing the future of surgical care, our building blocks are: number 1, to engage the leadership. Critically important at your hospital is to engage your hospital board in the quality and safety initiatives. They need to be part of the journey, otherwise it will not be successful. Culture is incredibly important. We did a safety survey at Ohio State 3 years ago. The results were dismal. We were concerned. We actually were astonished. And we needed to actually change the culture of the entire organization. And we implemented team training. Checklists and visual management can be incredibly helpful at getting traction around your quality initiatives. Critically important is also standardizing the processes. For example, handoffs or quality initiatives themselves. And then we have to figure out how to report these rare events that are like 1 in 10,000 or 1 in 15,000, and how to get a handle on them if we're going to actually improve. Selecting our benchmarks and setting our goals. This is an example of our rollout for our team training using crew resource management at our institution. Beginning in December of 2010 and carrying on even today, we have trained every single employee in our operating rooms, our catheterization labs, our labor and delivery units, our emergency department, our endoscopy suites, in a culture of safety that allows communication from the most junior team member to the most senior team member in order to avoid catastrophic outcomes. In addition, we have embraced the checklist as espoused by the World Health Organization and others, and this has become part of our culture. Every surgeon performs a timeout. Every surgeon sees the patient prior to going into the operating room, and every surgeon performs a sign-out prior to leaving the operating room. 3 years ago, we had a problem with hand washing. 20% actually was the frequency of surgeons and medical staff that were washing their hands. That's pretty low. We began an initiative, and that initiative now has gotten traction, and we're up to 90% compliance with our hand washing, and 100% on several of the units within the hospital. And we continually remind ourselves about this initiative and its importance, and have empowered our patients to remind us every day. We tried to standardize the handoffs, which are the Achilles heel, if you will, of modern care model in complex surgical and medical organizations. In addition, we have standardized our processes for understanding how to improve quality. There are many processes available: Six Sigma, lean. This is a process that we've adopted called DMAIC. Consists of 5 elements: define, measure, analyze, improve, and control. Defining the problem, measuring the key aspects of that problem, determining the data and analyzing it carefully for cause and effect relationships, optimizing our current processes based on this data, designing experiments around this, and designing process capability. And finally, we need to control the future state process that ensures deviations from the processes that were developed through the DMAIC methodology. Our specific examples of this at our institution have included defining through safety quality and safety scorecard that I'll share with you. I shared some of this when I visited McGill University last year as the Fraser Gerd professor. I'm going to show you how to measure very unusual events by using a G chart or a run chart. We need to analyze and determine underlying cause and determine tactics for improvement, implement those, and then very importantly, set and monitor our results. This is our scorecard that we use at Ohio State. We don't specifically look at the incidence of these events, but specifically look at the number of events, number of retained foreign bodies, number of wrong site procedures or wrong person events, medication events with severity, severe injury or falls, hospital-acquired decubitus ulcer. This includes all decubitus ulcer, not just level 3 and 4 that are required to be reported to CMS. Central line bloodstream infections, ventilator-associated pneumonia, hospital-acquired surgical site infection, and probably the most difficult of all to eliminate, hospital-acquired Clostridium difficile infection. This is an example of the G chart and the run chart. The G chart is shown on your left as you look at the screen. This basically tracks the date of the event and the number of days since the past event. So that what you are looking for a wrong site surgery, say you're tracking that, you may end up having 50 days since the last event. Improvement would be if you can get to 300 days. Understanding that we all want to get to 0, but in a complex organization and complex medical care, it may be impossible to get to 0 in every case. The run rate or run chart is basically looking by the date of the month at the days since the last event. We make greater use of the G chart in our organization. We have set our goals, as I indicated. That's one of the foundations. And we've looked to reduce our quality and safety scorecard events by 50%. And I'll show you how we've done. Improve in risk-adjusted inpatient mortality, achieve 25% reduction in readmission rate, and achieve top decile status in patient satisfaction. We benchmark ourselves on several performance measures, including University Health Consortium, NISQIP, and Society of Thoracic Surgeons. Others you can use are outlined here as well. Well, what about the value study? This is the next step of the painting, and this shows creating light colors or values and dark, we might be considered bad. So what are our results? I've had to put hypothetical numbers in here because the true numbers are confidential. However, if you theoretically propose that we had 5 retained foreign bodies in fiscal year 11, we had 1 in fiscal year 12, and 0 in fiscal year 13, we had basically 100% reduction in retained foreign bodies over the last 3 years with our induction of our crew resource management. Wrong site events have dropped, medication events with harm have dropped, falls with harm, injury have fallen, central line bloodstream infections have dropped and actually been eliminated in one of our care hospitals with up to 100% with no central line infections for 1 year. Ventilator-associated pneumonia has dropped, hospital-acquired infection has dropped, and yes, we are actually making progress on C. difficile enterocolitis. So we're close to our goal. We've dropped total avoidable events in this hypothetical situation by 56%. So this is a way you can really track your outcomes of your quality programs. Let's look a little bit more at the detail. This is a G chart on foreign body events, and you can see that our foreign body events as of April 2012, 311 days from the last retained foreign body. We can continue to monitor that. This is a event chart looking at surgical site infection and the implementation of our leadership goals, hand washing, and routine application of the SCIP parameters in 2012, showing a diminishment of our surgical site infection rates. And very importantly, we share this information with all of our staff, nurses and physicians, on a regular basis on our internal website. Well, I've talked about the system. Let's take a minute and look at the individual, because you can have a safe system, but if you have an individual that doesn't know his or her limitations, as Dr. Melvin has indicated, that can lead to a serious decrease in the quality and safety of your environment. We will focus now in the next couple minutes on the surgeon, and I'm going to actually show you a way to use some of this information to apply as a leader, a chief of surgery, a division chief, a leader of a group in private practice as you assess the members of your organization. I think we have a number of reasons that we want to do this. One is to assure high quality care. Obviously, we need to help our faculty and staff develop. Some of these elements might be helpful for appointment and promotion, retention decisions, and then recommendations to various certifying bodies. The chair or the leader or division chief each year has decisions that are made on faculty. The first is a new appointment, whether to promote to full appointment, extend provisional appointment, or indicate that there's no evidence of competency and deny appointment. New procedures, they have to demonstrate competency, extend provisional appointment, or have they not demonstrated that competency and go back to square one, or for reappointment. So how do we assess individual clinical performance? Direct observation, difficult, chart review, pretty standard, and prospective data collection. Direct observation is actually impractical. Time, location, subjective, expense, and it misses some important elements such as professionalism, judgment, application of knowledge. In our chart review, however, we can get some specific information about the individual's practice. This is done by a peer, sometimes by a division chief or the chair. It's done with initial appointment, 10 procedures. New procedures is critically important. As I indicated, we have to reduce that risk curve that is superimposed on our learning curve. And then ongoing, we look at 10 cases or individual circumstances every 6 months, and we look at a variety of elements that are really based around our competencies. In the medical chart review, we look at the medical knowledge, we look at our patient care, and we look at also patient complaints and events, as well as patient satisfaction. In our assessment of new procedures, we look at justification. Was the assessment of the patient adequate? Was the procedure necessary and appropriate? Were the technique applied appropriately? Were there complications? What was the post-op care like? And is the individual to demonstrate competency with the procedure? As one looks at standardizing introduction of new operations and new treatments, there are very specific guidelines created by SAGES for individual procedures. But this guideline created by the American College of Surgeons in 1994 on the heels of introduction of laparoscopic and minimally invasive surgery is really the gold standard that we use today. The individual must be a member of good standing, complete a defined educational program or preceptorship, must be qualified, experienced, and knowledgeable in the management of that disease process, and maintain the skills, and in our institution and in yours, probably undergo that initial practice evaluation. The key is to reduce the high risk during that first part of the learning curve to a low risk. Assessment of individual practice can also be done by comparison to peers, and we do this every 6 months at Ohio State. We look at activity, clinical outcomes, quality inquiries, citizenship, medical records. Maybe some of our younger faculty are not aware of that we're actually watching you during your activities. Resource utilization, pathology, et cetera. But I think it's critically important not only do we measure, but we actually have to use this information to make changes, to mentor, to coach, to improve the quality of our faculty. In order to do this, I'm going to share with you data on two hypothetical surgeons. The first is Gerald. Let's see. Okay. First is Gerald J. Marks IV, a general surgeon being considered for reappointment at St. Elsewhere University Hospital. He is focused on endoscopic and minimally invasive surgery, has an active lab and an R01 grant from the NIH. Another very gifted and talented faculty member is Dr. Rockstar, who is a surgeon also being considered for reappointment. His area of focus is the nouveau surgery du jour, or the new surgery of the day. He is noted to be a high-volume surgeon, has threatened to move his very busy practice to a major competing hospital, and he feels he is not being adequately compensated for the volume of surgery that he generates. So we are going to assess these two individuals on 7 components: mortality, length of stay, sentinel events, work productivity, contribution margin, patient satisfaction, and staff complaints. Now, how are we going to evaluate each of these individuals? And after I get done presenting the data, I'm going to have you individually evaluate and tell me what you think we should do with each of these individuals. This quadrant diagram, or performance and values, was really shared with me by a gentleman named Tony Rucci, who was the former president of Sears and the former dean of the School of Business at the University of Illinois, who is an executive with Cardinal Health, which is located in Columbus, Ohio. He shared with us, he said, listen, there are 2 things that are important. One is performance. That individual perform highly on the areas where you want them to perform. And do they have the values that are consistent with the high level of the values of your organization? He further went on to tell us that, if you're in this left lower quadrant, there may not be much that can be done. You're a low performer by measured outcomes, and you don't really have the values. Now, contrarily, if you're in the right upper quadrant, you have high performance and you have very high values as you measure them for your hospital or your organization. That's an easy decision. Those people are retained, perhaps get an increase in salary, a bonus. The other people in the other areas really are the ones where you need to use your skills as a leader, to either mentor them to enhance their values. I think mentorship is critically important in value development. And mentoring the individual to enhance their values, or coaching them to improve their individual operative performance or practice performance in order to move them into that right upper quadrant area. So let's take a look at our 2 doctors. So we are using the UHC benchmark criteria for mortality observed over expected. The average is 1. In the general surgery unit that we're talking about, the larger the bubble, the larger the number of patients. So you can see there's about 6,600 patients served by that general surgery unit, and the O to E ratio is about 0.67. Dr. Rockstar is an incredibly busy surgeon, actually about 650 cases per year, about 1/10 of the entire volume of that unit. However, his mortality O to E ratio is 1.47, as compared to Dr. Marks, who is a lower volume surgeon but has excellent mortality numbers. Well, let's look at the length of stay. You can see general surgery is about 0.9 compared to the UHC standards. Dr. Rockstar, unfortunately, again, is high, 1.3, and Dr. Marks is low, 0.6. Well, let's look at sentinel events. We all dread sentinel events: wrong site surgery, retained foreign bodies. Those are the types of things we're talking about. And you can see general surgery has had some sentinel events. Dr. Marks has had no sentinel events, and Dr. Rockstar is on the radar screen as having some issues during the period of assessment. Well, let's look about RVUs. We're all talking about RVUs. Someone told me that when they see me walking down the hall, they think I'm looking at them like they're an RVU. But I think that, general surgery is a high-performing organization in this department, and you can see that it's above the 50th percentile in work RVUs, and you can see that Dr. Rockstar is really high in work RVUs, like 90+ percentile. Dr. Marks has a more balanced portfolio, if you will. It has time that he is dedicated to the lab, NIH grants, educational pursuits. He's not performing at the mean of the AAMC and is performing below the mean of the general surgery unit. Well, what about contribution margin? When you go meet with the hospital CEO about, well, we'd like to have a little more investment in our surgical unit, contribution margin is something that they would like to talk about. And you can see that general surgery has a huge contribution margin prior to allocation of indirects, which is a topic for another conversation, but a contribution margin of over $12 million a year. And you can see that although Dr. Marks is a low-volume surgeon, has a pretty high contribution margin, whereas Dr. Rockstar has a lower contribution margin, largely driven by the equipment that he has chosen to use in the operating room in his new developed procedure. How about patient satisfaction? These are HCAHPS results. You can see general surgery hitting the mean of 90%. Dr. Marks, very high. Dr. Rockstar, unfortunately, low. And then patient complaints. Dr. Marks, exceedingly good. Dr. Rockstar has had 10 complaints during this period of assessment. So let's look now at where you might put these people. This is where I would put them. I can see I would put Dr. Rockstar in that lower area, the left lower quadrant. Certainly, if this was their first evaluation, you might give them the benefit of the doubt, put them in the left upper quadrant for some mentoring or coaching, perhaps. But I would leave it to you to make that decision on what you think you would do in that situation. Well, the finish. Finish is what you see in the painting. The artist usually does not really complete the painting. He leaves it to the person that is studying and enjoying the artwork. So I will leave you with the formula for success and how you think you would solve it in your own institution. It's been a great honor for me to present the Marks Lecture this year. I saw him earlier today and greeted him. He is a tremendous leader and someone that we all have great regard for. Thank you very much.
Thank you. Thank you, Dr. Ellison. It's my pleasure to award you this plaque in honor of your invited lectureship.
Thank you very much.